We'll talk about West India medical centers. And there we don't start with prayer, intention setting, nothing. So we are not going to do that today. We'll just start the session. So I'll obviously there are some slides to give full context. This is what we typically also share. So I'll go through that and please feel free to ask me to wait and ask questions, etc. And I'm hoping towards the end get to a place where we can share also how now we're planning to integrate yoga therapy at the centers. Yeah. Oh, sorry. Yeah. Okay. So yeah, this is the identity of Swasth India Medical Centers. The logo of green, red, and the white cross you see. It's slightly different than the institute, but yet similar. Uh, and the background of this, and as we see the program as well, you will see that the green cross. So basically, in India or in Maharashtra, at least, green cross is for chemist. So if you see a chemist shop, they will have a green cross there. And the Red Cross is, of course, belongs to the Red Cross Society, but typically signifies like a doctor, clinic, or a hospital. Technically, they can't use the Red Cross because it's trademarked by the Red Cross Society, but we sort of see it that way. So we couldn't use either the Green Cross or Red Cross, so we combined this and made the cross white, but we said left and right, and so sort of that's the theme that there is both a doctor and this. But anyway, let's get into why. So what's Swasth India Medical Center, sort of the essence in one sentence is this: it's preventing impoverishment through primary care for urban poor. Now, what does that mean? So if you look at some statistics, and this was sort of also, people who don't know the origin story of Swasth itself. This is how in 2008, when you starting Swasth itself, this was still true, and unfortunately, it sort of still remains true that in India, almost 60 million Indians, which is 1 in 20 families, right? So our population is about 1,200 million, 1.2 crores. Now it's 1.4, but about 5% of people every year go from above poverty line to below poverty, and that's due to a health shock. Or a health shock is, for example, an event like a big event in the family, or somebody having a heart attack, somebody having a stroke resulting in paralysis, kidney failure, and what they end up doing is they end up going to a hospital, and there they spend out of pocket money like way beyond their means. So as a result, either they end up selling an asset, or they end up taking a loan at some uh, ridiculous rate like 100% a year or something. And anything, either if they sell the asset, take a loan like this, they are in a debt trap, so they never get out of it, and sort of they sink into poverty and stay into poverty. And that's the vicious cycle of this thing. And this is, like I said, it's 5% of population happening every year. So these are people who somehow manage to escape all the growth stories, getting them out, but 5% are going back in because of health. And this is, as you know, primarily again in India, all a large portion of health expenditure happens out of pocket. So we pay as consumers. There's no insurance. Last few years, there has been a government scheme. It's, I think, jury's still out how effective it has been. But this is sort of the reality, pretty much, that this results in impoverishment. So this is the single largest reason again. World over, this is well known from a public health standpoint again. The typical norm is if the out-of-pocket expenditure is more than 20%, then it will cause impoverishment. This is sort of research, Harvard School of Public Health, etc. They published this 20% number. And we are at about 70%. So we are one of the worst countries in the world, and very few countries which are at this end of the spectrum of 70%, where people pay out of pocket for their health. There is no security. And as a result, this is bound to happen. This is just like basic, they would teach like first year students in public health that this is what happens if you do that. So this is the reality of India. The other reality which is also happening is that now the major cause of death in India, at least in Mumbai, definitely is not the typical dengue, malaria, TB, COVID, what we hear, but it's really non-communicable diseases. These are things like blood pressure, diabetes, thyroid. So we think those are rich man diseases. If that was still the view, please change that, because it's not. It's as common as anything. When we do testing, random testing at our clinics, we find 2 out of 3 people in the communities, in the low income communities, above 35, when we do a random testing, have either hypertension, diabetes, or both, or on the verge of having. That's sort of the reality we see day in and day out. And these are the people who end up not treating it ever. They get to know only when they have a heart attack. And they are the people who are dying. It's not the rich who is dying, because the rich reach the hospital, they have the medicines. These are the people who get a heart attack. They try to go to Sion Hospital, which is the busiest hospital, and also at the busiest junction in Bombay, probably, where it takes easily more than an hour to even get there. And that golden hour, everything is delayed. And the worst is if they survive, actually, because that means it's a 13,000 rupees a month, 15,000 rupees a month expenditure for the family after that. One is the cost then, and then the expenditure after that. So communicable diseases is becoming more and more very, very common. And this is Bombay data is there, 60% mortality. Just looking at deaths in Bombay annually, it's not railway train accident, it's not malaria, it's not TB, it's not dengue. All that we see in the newspapers, it is these. And these are way, way, way higher, 10 times higher than those. And this is not talked about. This is just taken for granted. So we are losing both wealth and health. That's the situation. And it's quite, yeah, in that sense, quite grim, really, around the health system. And it's still not part of the political dialogue. There are elections happening in India right now. And if you're seeing, this is hardly a part of this time, although I think in the manifesto of both parties, there is something. They're saying above 70, they will give health insurance, age above 70, etc. There's some dialogue that is, I think, for the first time, it's beginning to come, but it's really way down on the priority still. We spend the government spends less than 2% of GDP on healthcare, for example, right, in a country like ours. So, yeah, these are some just, very difficult statistics that are just true. It is just there. So the problem statement we started looking at, we said, let's focus on these silent killers. So we have had a journey ourselves of almost 13 years now in the Swasth India Medical Center, the program. As an organization, we have a 16-year history, but this program started 3 years into it. Yes. Madhuri, can please share, Madhuri sharing today's camp data that she did. Apparently today we did a screening camp and she's sharing with me on chat. 12 out of 21 people are hypertensive. Just a basic blood pressure reading is showing that. So can you see that screen now, this chart, people? Yeah, this is the data from today's camp. So 21 people came in, samples collected, we'll know, but 12 are hypertensive, 4 diabetic, 4 cholesterol, 2 thyroid already. So, and 6 of them have their blood pressure still out of control. So, yes, thank you. This is as live. So we basically chose to pick these two because these are the biggest and they are the silent killers. In the recent last 5 years, this was a Bombay statistic. They found that there's been a 5-time increase in deaths due to diabetes in the last 5 years. This is a report by Praja, another NGO which saw this data. And this is a fact that is well known through science research, established that early detection and management at primary care can reduce the incidence of health shocks. Right. So what we are trying to do is prevent these health shocks from happening. So just prevent, can people not end up with hypertension, with heart attacks, with strokes, with kidney failures? But can we detect them early? If we manage, detect them early, this can be reduced. It's that simple actually at one level, and that's what happens worldwide. Now, what is the challenge there when we try to look at this? We find that the current government healthcare infrastructure is just inefficient, insufficient, and poorly staffed. So the number of clinics in Mumbai is 23% of what needs to be there. So we are roughly at 1/5, 1/4 the capacity. And this 23% that is there, typically a doctor in 4 hours sees 150 patients. So in 160 minutes, he is seeing about, not sorry, in 4 hours, 240 minutes, he is seeing about 150, 200 patients. So that's about between 1 to 1.5 minutes for a patient. Yeah, so, and this 4 hours is being generous. This is the official time that is supposed to be present there. So I'm not going into that statistic, just giving the full liberty also, right? And in this 23%, there is staff vacancy in 30%. So 1/3 capacity is anyway gone because there is staff vacancy. And if a clinic doesn't have the staff, nothing happens. And more specifically to diabetes and hypertension, these are very, medicine supply is low. When a patient goes, he gets only 15 days of medicines. So every 15 days, he has to come back and stand in that long queue to just get the medicine. And as you know, Bombay, time is money. So the standing in the queue means a leave, which means half day of pay or a leave cost is there built in into that. So this is the state of public health. And when we, so hence what happens is entirely falls, the burden falls on the private providers. And in private providers, basically the fee for a specialist, because primary care providers don't treat hypertension and diabetes. If they get a patient, they detect, they will refer them, they'll write a letter, send them to a specialist for a simple reason, because writing a letter, they earn something, not just from the patient, from the specialist also. So without doing anything, they are making money. They are not taking any risk, no knowledge required. It just flows aram se. And they have their own regular clientele, more than enough of cough, cold, fever, diarrhea, respiratory tract infections, that they are kept busy. So it goes to a specialist where the cost of just a single consultation is 500 to 2,000 rupees. Right. And sometimes even 5,000. I'm just still saying 2,000 on a conservative side. And the medicines that they end up writing is at least 1,000 to 8,000. So you're seeing an average monthly cost of a patient from anywhere to 2,000 to 10,000 rupees. And this is just basic hypertension, which should be treated by the primary care physician in the first place. Worldwide, it is treated by the primary care physician, but it doesn't happen. So the net result is what? People just either don't go to the doctor. If they go to the doctor, they don't ever go back again. Which means if the doctor has written a medicine for him, blood pressure, take this. We have found patients who just say, we are very regular, we are very serious. I have been taking this medicine regularly, spending this 1,000 rupees a month for years, but never retested. So the result is that their blood pressure is not in control. They will still very likely end up with a heart attack. That happens. That's very common. We find that quite often. When we measure them, they are taking medicines, but it's not in control because they never went back to the doctor, never checked it again. Because if they check it, that's another 2,000 rupees to just visit the specialist. So it's just disproportionate. I think it's just very, very lopsided for the patient. So this is the situation. Maybe I'll take a pause here before we say what the solution or what we do at the Swasth India Medical Center, and see if there are any questions, comments, experiences on just the situation. Any questions, or yeah, would be happy. And Madhuri, feel free to add, because you are the real person on the ground. I'm doing it because this session, because she wasn't sure she will be able to make it today. But it's good. I'm so glad she's joined. So feel free to add if I missed anything. So yeah, any questions, comments as you hear this situation, ground reality, or what's happening with respect to in general in health and this. No?
I was just waiting to hear from Madhuri actually. That means I don't even know where to start, given I have been practically in this journey together
Yes.
since 2008. So
Yeah. And before, so your journey in health is before.
Yes.
Your journey in health is even before. So
Actually,
is mine. Mine is through McKinsey lens. Also, I have seen this as from the other side where I was serving corporate clients. And yeah, that was part of the motivation to even start this. Was it just yeah, it seems like a very competitive market. One might say it's a very fragmented market. but it's very consolidated in practice. It's very, yeah.
I think that means the biggest challenge has been not only for that means you try to, or that was the way we strategized, that we will focus on the low income, basically go to the slum areas and open the clinics. That was the whole plan. And I still believed that once we had that whole discussion about the 150 square feet of the clinic, in which how you have everything. But it is actually the thing is that, and I still grapple with that, and we can talk about it more as we go on, how to create a sustainable model on this, which is it does not need to be that means have that the returns that a venture fund asks for, but a normal return for somebody running a business.
Mm.
Because without that, we end up not being able to provide the service. That is the main thing, because that means you are going through the challenge that beyond a certain scale you cannot really do when you are doing it as an NGO, as a non-profit. So how can this, because this is so much freakingly required. I was just talking with the ex CMC Velo director, and he's currently head of health for ITC, and good friend, sitting down talking with him, and we are talking about how this model is required to be done from village to urban. That means actually if you go to the village, it is the same problem. In my village, when I have the health camps, it is the same problem.
Same problem. Yes.
How to, and that means we started in Latur, so we know the story. So
Solapur, Usmanabad, yeah.
exactly. So it is not different. How to actually create this thing, and to me, I think that is the whole thing. Everybody, how
Sure.
everybody can contribute to that thought, to how to create a sustainable business
Yeah.
model around, because the need is there, the demand is there. Actually, currently these people are overpaying for their healthcare requirement, right? So that is also there, that if you give a rational costing and everything, they will be able to pay for that. How to bring it together? How to bring it together and make it happen as a part of a comprehensive health system, and not just look at this isolated. I think that is the biggest challenge.
But yeah, I think before we get to solution, I also want to make sure others who probably, I don't know how many of you are familiar with this data, this
Yes.
state of affairs. You have obviously been in it along with me for 20 years in the health system, so you know the reality. But how has it been for others just listening? Hi, Pratik, Mercedes, welcome. Just seeing that this is the state, this is how, at least where we are in India. Is this new stuff? Sita, Andy, Kalpesh, Sonali, Pratik, Mercedes, or known stuff, like the extent of it also?
It's familiar with the this thing, but not like the accurate, like right now you've given us some percentages and all. So that was something that I was definitely not. There's no know-how about that. Yeah.
But your own like judgment, is it more or less than what you would have expected? Like mortality, the fact that almost 2 out of 3 deaths in Mumbai are due to these conditions. Is that, like, did you expect that, like, amongst the poor also, that 2 out of 3 deaths are due to hypertension and diabetes? That it's that big a problem?
I know it's a problem because I see it in my non-teaching staff.
Ah, okay. You do see that. So even deaths, for example, you've come.
Not death, but then, many of, like, I can't say the number of cases who have had strokes, who have had attacks. So therein, the last 2 years, I have been telling them that this is something that I would like to address. And so when that
Yeah.
space is not getting done, it's a little frustrating. So I know that is the need and that needs to be addressed
Correct. Good.
urgently. And there
So
are
you're
many
seeing health shocks there. You're actually seeing
very
health shocks,
much.
very high frequency of health shocks, as this is suggesting. Yeah. And that's, I think, again, Madhuri can share her experience after this. What
What
does
I
she see
also
when?
experience amongst my the elderlies in my family is also once you start the medication, as you said, nobody goes back. If दे दिया है, अभी तो अच्छा ही चल रहा है ना, तो फिर क्या? Why do we need to keep going to the doctor to check?
Yeah.
Everything is fine. That means this medicine is working. Why do
Correct.
we need to go?
Correct.
It's a huge challenge.
Huge challenge. That's the silent killer part. It stays silent. The blood pressure will not be in control, and you won't know. You will keep taking medicine. You think it's right. Yeah, exactly. Those are very. Yeah.
And when you suggest alternatives also, and you say, okay, you need to do this, I don't know where the resistance is coming from, but it is there. Even forget the lower income strata, I see that in the middle income group.
Yeah.
That's
Right.
very surprising.
You're right. Well, alternative के लिए तो अलग ही एक और barrier level higher है. So there's no demand per se, right? You have to generate that demand. People don't naturally want these solutions. Good, thank you. And hopefully, let's see. I don't know. Hopefully, Madhuri is also listening to you. What the people in your non-teaching staff need. Yes, Andy. Go.
I was going to say that the first time that I saw these stats, and it was in this presentation that you sent to me, I think a few months ago. I think it was a shock. The prevalence as well as the mortality, like both of those were way higher than I expected. And I had to sit with it for some time to just sort of let that shock kind of settle in. And then it started to kind of become a little clearer, how much of the way that how we live has evolved is starting to contribute to it. And everything about food systems and how the food systems work, how the nature of how we live has evolved. And I think all of that web of causes and conditions started to at least become a little clearer. And I have not lived in India for almost 17 years now. So even though I have great genes on both sides of the family as far as hypertension risk and cardiac disease and all that is concerned, I think just realizing how much more risk exists among people who don't have the time, the capacity, the resources to actually even understand it or do anything about it, don't have access to the tools. And I think the food system is sort of a global problem. The way healthcare works is sort of a global problem, but it starts to get like much more amplified among communities with less resources, less capacity, less time as well to actually like understand it. So I think like that, more than anything else, I think it gave me more motivation to sort of like do whatever little I can to help. So I think like that was sort of what it led to.
Yeah. Thank you. Okay. Anyone else? Yes.
Hi. I'm audible, no?
Yes, Pratik. Go ahead.
I was there for 2 years in Bombay studying public health at TES, and we worked at M East Ward.
Ah.
And this M East Ward project kept on continuing for like centuries, and from civilizations, but the figures are the same.
Same, yeah.
I mean, I had gone there as an engineering South Delhi brat, you know, and the figures really shocked me. And then we went to the rural Chhattisgarh and the other Indian belt, and I always felt that yeah, the poorer communities are only dying of waterborne diseases.
Hmm.
But then in rural Chhattisgarh, we saw a lot of suicides, a lot of mental health issues.
Yes.
And I thought we don't know part of this country, you know. So also for people who understand poverty, it's not linked that suicide, mental health, hypertension be become part of tribal belts. And since then, I've closely worked with the trans community. I've now worked with disabled children, and I see access to health is just in a bad shape. And so I was eager to know more what Swasth does.
Oh, good. Thank you. Yeah, thank you for sharing that. East is anyway very, yeah, it's a different problem, order of problem magnitude only in Bombay. So and that's the other complexity of primary health is this, that it's very, very local. So like he's giving example of one out of the 23 wards of which is within the Mumbai municipal corporation limit. There is Navi Mumbai, Thane, those are separate municipal corporations altogether. And there's one ward in out of 23 of Mumbai, and it's very different. So each ward is unique. So primary healthcare gets very local. Every city, every municipal corporation is different. But even in the municipal corporation becomes very different sometimes. Like at least in Bombay's case, I know it is. We also see. Yeah, so that's an important thing to keep in mind in primary care at least. Yes, Kalpesh.
So, my experience, I have seen like couple of more issues apart from what we have already discussed, right? Yeah, as Andy said, there are food is the global problem, right? Pratik said waterborne diseases are prevalent. What I've seen is say in most of the cities and towns, especially in India, the air also is not breathable, right? So, and that air is something the kids when they are born from say first few months to first 5 years, most of them have breathing issues. My kids had breathing issues. I went to the doctor and he said this is common in the cities, right? It is common. The allergy, breathing problems are common, and so that is another problem which is happening. Uh, uh, Almost every city has people like almost 30-40% of the kids have breathing problems.
Yeah, yeah, it's true.
And another problem which I see is that people once they have these problems like high BP or say cholesterol or say mm, all those problems, even after having that problem, they think it is okay. It is one tablet a day, that is fine. I'll live with it, right? And that attitude, I think, is another problem. They don't change their lifestyle. They don't change their food habits. They think, okay, one tablet a day is okay, and I'll live with it. I think that is also a bigger problem.
Yeah. Oh, that is, yeah, that's the next order. Oh, one tablet a day is 1 out of 7 of the people who have it. बाकी 6 तो कुछ भी नहीं करते. That is a real statistic. So you are saying, अभी everyone else should say, वो one, if they are taking, that's a very big thing. यार एक tablet a day भी ठीक से regularly ले रहे, if they come to the doctor regularly, that's a big win for us. Because 6 out of 7 don't even do that. So just, जैसे हम लोग बोलते हैं राम भरोसे अल्लाह भरोसे ही चल रहे हैं सीधा लास्ट स्टेज पे आते हैं बट या दैट इज टैबलेट अ डे पे भी चले but also as it there's no systemic change so there is no demand like Sita was saying alternate you suggest something there is nobody who is a taker in urban so definitely not very hard because time is so hard to get hold of.
I want to share one more because it was so disheartening and so sad. One of a very close friend of both me and my husband. I know him, they have moved out towards Coimbatore now. But on a given day, a few years back also, I would always see boxes of, एक डब्बा नहीं, 4 डिब्बे जो है मिठाइयों के होते थे. And he would eat. And that time also I would tell him, I said, Suresh, everything in moderation. Ab acha lag raha hai. And typical those, I feel when my husband is from Calcutta, he's from Kolkata. तो मीठा के बगैर बिल्कुल नहीं चलेगा. I said, ठीक है ना, थोड़ा सा खा लेते हैं, but you can't have so much. And you won't believe it. It's when we went to see him in Coimbatore, it was a shocker for us because of his HbA1c had shot up to almost 14, 15. And he didn't even realize that there was sepsis which had set in. I mean, I don't know. They are doing vacuum therapy. There's so much of sepsis. His both the feet are badly affected, and two of his toes have been amputated. And today, when we see him, he's hardly able to eat because you can see there is, I'm sure the liver has got affected. I can see his belly now a little different, and I'm worried. I didn't tell it aloud, but I'm worried about his kidneys. So, I mean, see, this is what I'm saying. Educated background may be ye laparwahi. So I don't know what is it that needs to be said, done, which will drive some sense into them.
We'll share a little bit, at least what we are trying at the clinics. Some little bit has gone into it. Something now is, I'm at least hoping something seems to be working with some numbers. We are seeing typically like instead of 25% people with blood pressure in control, the people who are with us, we are able to see about 60%. So it's almost 2.5 times of what the norm is. So we're coming close to most best practices in the world type places ki हाँ भाई इतना तो हो रहा है अभी next order is what your problem is also 60 का भी 100 तो बहुत दूर है ये 40 को कितना हम कम कर सकते हैं but some things are I think some things are working around education etc which we'll try and share a little bit. Madhu, you wanted to say something? Sorry.
No, I was just wanted to add what Sita was telling now. So actually there is lack of pain in sugar and BP. So they don't feel any pain. So that's lack of pain is something giving more problems. As we have seen like so many patients living with like systolic BP 220 or 230. So my highest was like not mine. I have seen the highest is 232. 232 is systolic BP, and diastolic was 120. So that was, and they were like living like a regular life, no worry, no tension, no any dizziness or not any pain. So that's the main reason of worry. And I know the people who are not doing anything instead like despite of these readings of like, hypertension, BP. I've seen patients with like 700 to 800 mg per dl sugar living. It doesn't bother them.
Yeah. Anyway, so yeah, so yes, the situation is quite grim to say the least. It's a lot is happening. Let me share a little bit now of what we are trying to do, what we have tried to do, where we are, and then see what we can do more. And I think see take up questions like what Sudeep was raising earlier. So what are we trying to do? This I'll share. These are articles. So this Swasth India Medical Center is basically a network of no frills. There's just bare bones just around the corner, meaning just in their neighborhood, local, one-stop shop. I think that was a very important part. Primary care clinics focused on these silent killers. I think we have all emphasized how important this word silent is, and that's a big part of the problem, at least here. So this is what we're trying to do. So what happens, I think, just to give a more look and feel of it. So this is how a center, this is our like, yeah, some of our branches, how they look like, very basic. They'll be right next to their kirana shop or the bhaji wala. So right in the neighborhood, 150 to 200 square feet. Typically, as you can start guessing, it's this one is this big only from right edge, the rightmost is this big, almost you see the full. So there's a doctor's chamber here. So this is what then it has, a doctor's cabin. We collect blood samples. All blood test samples are done here. Then all the medicines are stocked here. So this is the one-stop shop. You get a doctor consultation. Your diagnostics are done here. So ECG is also done here. And all medicines, the treatment is also available from from there. And all of this is basically the medical quality of care is at par with whatever I think is best in India. So the medicines are all strip packed from good manufacturers. There's no loose medicine. This is what anyone would buy. And in fact, I think my mom's treatment, for example, we use the same medicine. So that's the quality standard we get. Same for blood tests. That it has to be something where medically it's the same. There is no difference, but it's no frills. As you can see here, there is no AC. It will be in a place where you can't park a car, and it's in the community, the community that we serve. So it automatically filters out, like we only get the clientele that we are seeking mostly, that do end up coming there. So some of the key things that sort of even in this, what we have done differently or tried to do differently. One, as I said, it's a one-stop shop for all of these. And why that is important is because just this process that the patient comes in to give a test, he would go to a lab, spend another 30-40 minutes to go to a lab, stand in a new queue, give the blood test, then go back again in the evening, collect the report, come back with the report. And some of you are nodding, so you have also done this, right? Even because we have patients, we do this in India. Come back to the doctor, then the doctor will write a prescription. Then you go to a chemist. If it is nearby, you will walk, but typically you may end up going a little far away. And in case of low income, they are asked to actually come back with the prescription to the doctor so that the doctor can explain, because they can't read what to take when the prescription, that doesn't happen. The chemist doesn't explain. So they come back to the doctor and then the doctor will tell them. So that's another. So you can imagine this is a 3-4 hour process at least, which we are able to reduce to about 30 to 45 minutes, right? With just making sure it's one stop. They come in, if they need a blood test, the sample is collected there, report, they come in at the same place, get the report, show the doctor then and there, and get the medicines from there, whatever the doctor has written. So it all basically becomes a much, much shorter interaction for them. And this is right in their neighborhood where they would go for their vegetable shopping, for their groceries, for any other purpose, right? So this is, I think, one thing which has been very important. The other is this, which is we have been able to train primary care physicians to and build their confidence to manage this, right? So otherwise, basically, as I said, you would end up going to a specialist, and nowhere in the world specialist treats this now. It is treated by primary care physicians. So protocols are very clear. The government of India is promoting it. The state governments are promoting it, but it doesn't happen. So we've sort of standardized protocols, trained them, built their confidence, supported them, and now primary care physicians actually train. And what this means, why is this significant? Because one, it suddenly increases the capacity. It increases the capacity at least 100 times, because the number of specialists in India are like handful, while the primary care physician network is much, much wider, right? So that means that the person can be really in their neighborhood. So they don't have to travel to get this. The person can spend time in actually 5 minutes, 10 minutes and not do it in a rush. That's the other implication. And third, of course, is the cost. And we'll see those numbers, how cost of this consultation has come down from this 500, 2000 to now 50 rupees, essentially, right? That's the level of cost reduction that we can bring in. And if you have to make this viable in any form, that is essential. Without cost reduction, we can't make it anywhere close to any form of viability, whether through donations or any other, right? So we've reduced that cost, maintained quality through this training. Then the other thing, this is, I think, very important. This is the point, I think, which Sita, you were also talking about, on how to motivate patients, right? So this building ownership of patients has become very important, we realize, for these conditions particularly. And the two key innovations, we have done multiple things, but this first one is very important. We start with education actually before they are diagnosed. And this is something we have learned. We earlier used to do this. We'll first do a camp, which is what typically happens. People will come, acha, diabetes wale sab ek jagah aa jao, all diabetics come together, all hypertensives come together. Now we will educate you about your health condition. And we found that what was happening with that was many patients would drop, even from diagnosis to coming to that education session, number one. Number two, whoever came also felt very stigmatized, almost traumatized by that experience, that you have singled me out. Right? So it's like you have identified me as in a bad way. So what we realized, what we started doing was we started educating generally people. So we would hold community meetings of people above 35, which is the image Madhuri was showing of that camp. We would first educate them. We'll educate them not also about hypertension, diabetes. We would educate them about health shocks. Well, exactly again, what Sita you said, people know health shocks. They don't know hypertension, diabetes. They are silent. But health shocks are loud. So we start with health shocks. And actually, that's the question that we ask there. Do you know anybody in your nearby who has had a heart attack or a stroke? And I think out of these 20 people, at least 5 people raise their hands. That they know somebody very close by in their family or like immediate neighborhood where they have experienced this. And then we asked, what do you think is the reason? They say, Pata nahi, ho gaya, Ram bharose, God kind of thing, destiny. And then I think when we connect that to saying this is preventable, that's when we have seen there is sort of an aha. Acha, this is preventable. And then we connect it with hypertension, diabetes, and say how that can happen. And by the end of it, we ask them, now do you want to get tested? Because above 35, the risk is very high. And that's when people voluntarily now test. So they test for their blood pressure, they test blood sugar, and then we say for your results, come to the clinic for the at least the blood test. And that's where from the community, they are linked with the clinic. And what this has done is, it doesn't traumatize people, it doesn't stigmatize them because they are now aware before. And once they see, okay, some people got detected, some didn't get detected, so they don't feel singled out. They don't feel, you have targeted me. Because now this mistrust with the hospitals is very high because they think, you are picking me, you are over-diagnosing me because this is your business. And that is another reason why we have to do it donation-based because of that mistrust, but we'll come to that later. But this has enabled people to then say, okay, now I have been diagnosed, what do I do? Now then the doctor starts them on treatment. They are much more open to the treatment. And now once treatment starts, this second innovation comes, which at least the name Anushasan card, I give the credit to Atha Yoga Anushasanam. We're saying, let's bring in Anushasan, let's bring discipline at least, adherence. So we create an Anushasan card for every patient, make it very transparent, what you are supposed to comply with. To start with, we are starting just with regular follow-ups with the doctor, saying you come on time, you get your medicines regularly, you do your blood test regularly. Right now, no diet, no nothing, but start with that because that is also not happening. That's what I was telling Kalpesh. 1 out of 7 is just doing that at the minimum. Right? So can we get more people to say a discipline is needed? So we started with medicines only. And that's the Anushasan card. So people come in, they get a date for the next appointment. They come for the appointment. If they are late, they sign, I am late. So they have full transparency into whether they are coming on time or not. And that, I think, has been a big benefit, I think, in building this ownership for people. Saying, I think this also we borrowed from Sanjeevani, the 3-month program, that checklist, and some of you who have been part of that know. So we said, how can we make this a regular thing? So this card is there. It's filled by the staff, filled and signed by the patient saying, I'm doing. So we are doing it for them in some ways. Not at their homes yet, but at least saying, are you coming and getting your medicines, your testing done regularly? So this is a borrowed thing from Yog, but very, very helpful, Anushasan. And last but not the least is extensive use of technology, because that's the only way I think we can do anything, again, meaningfully at scale, at reduced cost. So use a lot of point of care diagnostics. I'll show some of these that we use. We have an electronic health record system, which is integrated with standardized operating procedures. We are able to prioritize who to target, what to do, appointments. So a lot of use of technology, our dashboards that is there, which helps us prioritize what has to be done. So technology is very, very key in this. Let me see. Yeah, so these are some examples of technology. For example, this is the ECG machine. We use the GE ECG machine, which gives auto interpretation. So you can see here, it says normal rhythm, non-specific abnormality, etc. So it's automated. The report is generated, the graph is generated along with the interpretation. And if there is some abnormality, that is escalated both to the doctor and if required even to the specialist. So this we have made it again accessible at primary care level, very important, and almost everyone with hypertension with any of these conditions, it has to be done once and annually, ideally then. Then the other is this, you're talking of diabetes and diabetic neuropathy. So in diabetes, one of the common complications is that the nerve sensation dies down. So particularly in the extremities like our foot. So this new device, this is very new in the market, developed actually at IITB. So this helps in a very simple way give a map of what is the level of sensation here. So red of course means sensation is gone. It's very low. So in these parts it's there, the degree it's telling us through this. So it gives a very visual report, very basic. So again, a nurse can do it. You don't need a doctor to do it. Very easy to administer. And the report is intuitive. When patients see this, they also understand what this means. Red means not good, green means okay, where it is good, bad. So they are starting to get a picture of how the disease is progressing. So again, trying to make the disease more relatable, more tangible, less silent, right? Because that's the problem with these. These are silent killers. So just making them more, giving the diseases in some ways a voice through these very visual reports. Then, yeah, as I said, records. This is my record. We have a mobile app where patients can access their entire health record, the entire history. This is my mom's history, and also download both the case paper, the reports that are there. This is available through their Gmail ID or OTP based login. So our EHR is there. I don't know how many of you have an EHR with your provider in India, but at least we've made it sure they have them. And they also get physical copies of their reports, because in this segment we need both. The idea is they have their report always with them. So if they ever end up going to a hospital, the entire history is available. They don't have to struggle to the other doctor as well. And this is like prioritization, very much. So this is a patient's, like which patient, how Anushasana they are. So highlighting the ones which are less than 60%, for example. So conversation can happen if the blood pressure is in control. So 140/90 is the limit. So it will show up and say, okay, talk to this person, what is happening? Talk to the doctor sometimes, or does it require medicine change? All of that, right? Somebody who is not visited for more than 60 days. So these are the conditions where we are able to prioritize and target specific interventions. And this is done by a team of community health workers, right? This is again a place where people can volunteer to do these conversations. Again, motivate people, talk to them to say, okay, can you just come to the doctor? Don't miss your treatment, because that is the first step to ensuring that you are getting better care or getting your values in control. And then we have these dashboards. This is actually shared with the entire team, the clinic team, the doctor, the nurse, and the receptionist, to help them prioritize. This is also giving you a sense of scale of operations. We see about 9,000 patient visits every month across the clinics. And even within a month also, there is repeat. As you can see, it's about 6,000, 5,000, 5,500 people. These are the registrations every month, new registrations. So we are registering close to 300, 400 new diabetics, hypertensives every month, right? So these are new registrations every month that we are seeing. Around 1,500, 1,000 people are registering at our clinics every month for their treatment. This is the mix of patients. So these are Anushasana card holders. So November was 6,200. I think this month we've crossed 7,500. So we have about 7,500 people with hypertension, diabetes registered right now, coming on a regular basis. You can see this percentage active Anushasana, that's 60%. So as I said, this number is itself a big improvement, that 60% of people, of patients, known hypertensives are coming regularly now. I think this is a habit we have been able to cultivate now. And this number is, less than 25% if you just go random sampling in this segment who come regularly. So we've been able to get that to 60%. And all of this is due to the innovations that I was talking about. I think that's helped. And it's been a learning process for us as well to get there. The thing that we track, these are the two things that we track as also impact patient satisfaction. So we are at 4.5. It's very similar to what all of you get at Yog. This is what the institute copied from the clinic, from our first patients. We have been calling them up, just like Ola, Uber rating. We said, just rate us on a scale of 1 to 5. Here we don't do it on a mobile app, but we just call a random sample. We are at 4.5, sometimes it's 4.7. And how much money have we saved patients? So you can see 90% reduction. So patients are paying only 10% of what they would have paid had they gone to a private provider. And this is important because if you remember, I said out of pocket has to be less than 20% for it to be meaningful. And we are at 10% today. And that is, I think, for us very important because, and that is where the tricky part, I think, where Sudeep was saying how to make it sustainable, etc. We'll have to see without changing this, because I think this is a very important part of why the adherence is at 60%. Why are people coming regularly? Why is there, we'll see blood pressure more in control? Because they are coming regularly, they are adhering because the out of pocket is low. It's a big part, and this is world over studied. We can have a little out of pocket, but nowhere close to where it will keep our cost covered. So whatever we collect from the patient, this 10% covers 20% of our cost. So we'll have to collect 5 times of that to be sustainable just from patient collections, which will, I think, basically twist this or deviate this from it. So these are the kinds of dashboards that we continuously monitor. We see it at a clinic level. So we are able to go deep dive, diagnose. And this is a dashboard which compares all clinics like any other system, good, reasonable variance. You can see some outliers here, some here. So very much like any other portfolio. But this is what helps us. This is November data. Since then, I think we have worked on some of these, pushed them here, but some move here. So all this keeps happening. This is what Madhuri does day in and day out, I think. And to summarize all this results-wise, what we have achieved, and then I'll open it for more questions. What has been the result? So one, reduced cost, as I said, dramatically. Very important to make it anyway viable, even with donations or in any way. So we've reduced the cost of doctor consultation and the overall cost. So doctor consultation, as I said, has come down from 500 to 50. You can say from 2000 to 50, because out of the primary care physician doing it at this scale, cost is much, much manageable. But even the overall cost of primary care delivery, we have reduced it dramatically by 40%. And this is combination of things like we run our own drug warehouse. So we have a place here, we purchase medicines directly from manufacturers. So we have reduced the cost there and they are supplied to patients. So we are not, so to give you again a sense of numbers, if you as a patient or I as a patient go to a pharmacy and buy a drug for 100 rupees, the actual cost of that drug is less than 10 rupees in India. It's not 10% discount. It is 10% is the cost. It's 90% discount. That's the reality. That's what patients are paying out of. So we are able to purchase it at 10 odd percent from manufacturers, 10, 12%. A little bit of our cost of supply chain, logistics gets added to it. And that's what's keeping our cost very low. Similar is the story with pathology lab tests. So that's why this one-stop shop format actually is very key to reducing this cost. Otherwise, we wouldn't be at these numbers and the numbers that we need. So, for example, the cost of care for one person now on a month basis, everything included, all regular testing, medicines, doctor consultations, on an average for a chronic disease person is between 400 to 500 rupees a month, which is about what, $5, right? So $5 a month or $60 a year. With some people in US was telling me this is like copay, probably for one transaction. But at that, we are managing the entire treatment, drugs, medicines, lab tests, doctor consultation of the patient. And with these results, that their patient retention is higher, as I said, and the patients in control is higher. This is the most important thing at the end of the day, that almost tripled the number of patients who have their blood pressure in control. And the reason is simple, because the patient comes back. The doctor can change the medicine if needed, which doesn't happen. Even for people who are buying their medicine, spending 2,000 rupees, 5,000 rupees a month, their blood pressure may not be in control, their diabetes may not be in control, because they are not testing. They are not going back to the doctor. So that alone, we have, these two are the other two metrics where we have improved the the metrics as well in terms of how much this is in control. Reduced cost, improved quality, and patient satisfaction is better than both other private and public providers at 4.5. Others are close to 4. The public is lower than that, the government system. So I'll take a pause here, see if there are questions, comments on what we are doing and what we have done on the innovations, and then we'll see what next. Sorry, one quick slide which I missed out, just to give overall perspective. Since 2011, we have treated close to 1.5 to 2 million patients. We've done it, as I said, at 4.7 million, not patients, sorry, patient interactions, not number of patients. And we've saved them about 25 crores rupees, which would be close to $3 to $4 million in terms of the money that people have saved through this system. And in terms of right now, today, if somebody donates to us $1, what the benefit that the patient gets from that $1 is close to $3. So we are able to multiply the donation in some ways, or the money, you can say, invested in us or donated to us is multiplied, because the patient, the value of the service that the patient gets is 3 times of that, far more valuable. Yes. I'll take a pause here, see, and then we'll talk of a little bit about maybe what we are trying to do with yoga therapy also, what next with this. But yeah, any questions, comments about anything, yeah, about the innovations, whatever is your reaction to that? Makes sense. Or ideas also now, as you hear it.
Just want to say that this is just fantastic work. So hugely appreciative of you, Madhuri, the entire team for everything that has been done so far.
Thank you. So this also happens, I think, today or tomorrow, or like in a day or so. Madhuri is completing her 10 years. Correct? At Swasth. Madhuri, can you join the video for a minute and show? When is the date? Today, tomorrow, or something like that, right? Tomorrow or tomorrow? Okay. So she's completing her 10 years at Swasth, and both a mix of the institute and starting at SIMC. Maybe you can share a little bit. Maybe now you say, or it's been your experience at SIMC. Maybe it's a good time to, yeah, recollect your 10 years also.
Thank you. So 2014 I joined, and at the time I was really looking at the clinics grassroots level. I was supervising the staff, and then I started doing the service delivery part, like back-end services I was looking at, and I was service delivery supervisor at that time. And then we started doing the regional management. So I was regional manager at that time, and we were handling the clinic operations, or the like daily operations of the clinic, staff issues and everything, looking at the staff satisfaction at the time. That's still that was till 2018. And 2018 I started working in yoga part. So I was looking at the yoga, like to make the curriculum, and to really work with the patients. So to have the batches with the patients, to teach them the practices and everything I was doing. And that was for 4 years. And now I'm trying to integrate yoga and again the clinics. So there's the integration of yoga therapy for all the patients. I'm very happy to share that we have piloted yoga therapy integrated care in one of our clinics, and that has a tremendous response. People are like practicing since 1.5 year and they are still practicing daily. That was the biggest achievement. And yeah, so before this, when I started yoga therapy in clinics and piloting the project, so I was thinking, no, we will not get the enough response. But in that clinic, the response was very nice, and that gave me courage to really to spread this integrated way of care, which includes yoga therapy and plus allopathy medicines. So now, actually, I'm happy to share that doctors are now seeing the benefits of yoga therapy. So doctors are sharing, asking that from when you are starting, ma'am. So yeah, so that's the good news, that allopathy doctors are now seeing the value. Yeah.
So, wait, sorry. Give me a minute. I will a few minutes. I want to share the videos of some of these participants. So I planned it. So let me share that, and then you can talk a little bit more, and people can ask. So yes.
Yes.
Yeah, you can see the YouTube link. Yeah, can see. Yes, and audio also. No?
मी मनाली मोहन मोडक, माझं एज 42 आहे. मी कॅन्सर पेशंट असून मी माझी ट्रीटमेंट टाटाला चालू आहे. त्याच्या केमोथेरपीमुळे मला भरपूर विकनेसपणा आला होता, म्हणजे एकदम थकवा वगैरे जाणवायचा प्रत्येक कामं वगैरे करताना. ते आता सध्या मी आता इथे 5 महिने येऊन योगा चालू केल्यापासून मला आता फ्रेशनेस खूप चांगला येतोय माझ्यामध्ये. म्हणजे आता जशी कामं करायची एनर्जी पाहिजे होती तशी म्हणजे आहे, भरपूरपैकी आहे.
नमस्ते मैडम जी, मेरा नाम मीनाती नाहक है। मैं 50 ईयर्स की है। मेरा ना पहला मेरे को बहुत गुस्सा आता था। जब से योगा क्लास ज्वाइन की तब से बहुत अच्छा हो रहा है। दिन भर काम करने में भी थक जाती थी, अभी तो बहुत अच्छा फील हो रहा है। ऐसे थकती नहीं है, दिमाग भी ठंडा रहता है। और मेन बीपी का गोली तो बहुत चालू था 1 साल से। अभी यहाँ डॉक्टर से ट्रीटमेंट करके मालूम पड़ा वो आधा गोली किए, फिर अभी तो बंद ही कर दी। 5 महीना से योगा क्लास मेरा बहुत अच्छा जा रहा है, अच्छा फील भी हो रहा है मेरे को, बहुत अच्छा लग रहा है। हमारा योगा मैडम लोग भी अच्छे, और हम लोग को योगा अच्छा हमारा ज़िंदगी में ये बन के आए अच्छा से, भगवान बन के आ गए अच्छा से।
माझे नाव रंजना बाबुराव सप्पा। माझं हे गुडघं दुखायचे, गुडघ्यांचं म्हणजे 10 वर्षी मला दवा चालू होती। 10 वर्षी मला एवढी दवा खायची पण मला थोडा पण फरक नव्हता। आणि हे हात सुजायचे, हाताची सुजन होती। आणि ते मी योगाला आले 5 महिने झाले। 5 महिन्यामध्ये मला एवढं मी बसायला पण लागली आणि माझा हात पण, माझ्या हातांची सुजन पण गेली, पण मी आता काम पण करू शकते घरी।
मेरा नाम फातिमा अंसारी है और 60 साल का उम्र है, और मैं कम से कम 10 साल से दवा करा रही थी। मेरा यहाँ तक कि ऑपरेशन का नौबत हो गया था, ये दोनों घुटने का। लेकिन मैं जब से योगा में आने लगी, माशाअल्लाह, अल्लाह का शुक्र है कि मुझे बहुत आराम है, बहुत आराम है। यहाँ किसी चीज़ का परेशानी नहीं है, और अभी भी थोड़ा बहुत तो रहता है, धीरे धीरे तो जाएगा। है सब बहुत नॉर्मल है, बहुत अच्छा है। और मैं बराबर आती हूँ, वही संडे को, शनिचर को कभी कभी नागा होता है, नहीं तो मैं बराबर आती हूँ।
मुलाला चौधरी आणि आम्ही इथे योगामध्ये आलो। नंतर आम्हाला योगामध्ये शिकवायला लागले। शिकल्यानंतर आम्ही चांगला वाटायला लागला, हातपाय दुखायचे बंद झाले, डोका दुखायचं बंद झाला। नंतर आम्ही दवा चालू झाला। दवा चालू केल्यानंतर आम्हाला पैसे कमी लागायला लागले। पैसे कमी लागले तर आम्हाला फायदा झाला ना।
जेव्हा जग धोक्यामध्ये असतं, येतो जॅव्हलिन मॅन.
Yes. So these are the participants from what Madhuri was talking about, the pilot. Yeah. So this was very interesting. I'll add, if you can hear me, right, Madhuri? Bolo, you say na about the pilot on what were your learnings, etc. Please.
No, nothing to share more, like the self-explanatory videos.
Self-explanatory. So the pilot. So I want to share at least Madhuri is being very humble because it took almost, I think, 1.5 years of failure first. So getting this yoga pilot going, we tried so many ways. This timing issue with people, what will get them in, generating this demand. For 1.5 years, we tried so many options. We would do a workshop. 50 people would say we will come to the workshop. Then only 20 will turn up. Then we'll tell them this is what we are going to do. Then the 20 will say, 18 will say, I want to do this, very interested. And then we'll start the sign up process. Only 3 will turn up. So then, and this was a 3-month commitment. So Madhuri did the batch with those 3 people for 3 months also. Well, we had committed, but we said, yeah, something is not working. So it took many trials, errors, etc. to finally crack this model key, how to make this happen. And today the status is, we actually, out of these people who came, we had almost a 97. I'll share these numbers just now. Let me show that slide also. We will put this amazing. But this is what told us these people still need this if we do it in the right way. The attendance in the workshop was 97% in the 2-week training. 97%. This is across people. Their attendance over 2 weeks was this. Then on the daily practice, 78%. People coming physically every day to a location. And this is about what? I think 15 odd people, if I'm not mistaken, in that range. Monthly consultation. This was another thing we said, that you have to meet the one-on-one with Madhuri. 90% was the attendance. And we saw blood pressure reduction of 18%. In systolic, the upper, lower by 11%. And you have heard these stories that way beyond blood pressure, this has gone. Right? This has gone way beyond. Joint pain is such a common problem which is so often ignored. And then just amazing impact. I think we just were so happy to see. It seemed and now, so the way this was done, I think I want to share that. Madhuri is not sharing, but so this was done here. So this is the community place. This is a temple. This is a temple hall. This is a Gurudwara. So people came in, and Bombay being Bombay, we had to pay rent for this also. So the Gurudwara didn't give it to us for free. We thought we were not charging any fee to the patient. We said we are doing it free, but the Gurudwara said, no, this is a hall. We make revenue from this by giving it for various events. So for you, we will have to keep it blocked for 2 hours or 1.5 hours a day. You will have to pay us rent. We were paying 5,000 rupees. So once our pilot ended, after a year, the budget ran out. We said we can't do this. So then the people who were still continuing, they decided to say, no, we will figure out a way. And so now they do it every day in a garden, which is free. So they found a much more creative solution. They go to the public garden, do it today. And still, I think Madhuri keeps getting their photos, right, that they are doing it. Madhuri is not going. One of them has become the person who organizes it, one of the participants only. So it's like a self-appointed coach, if you may, almost like that. She's saying, I will facilitate the session. I'll get people together. And she's giving. We went to, I think MLA also you went, right? One of the politicians, they can now BMC, no support. But people found a very creative way. People found a very creative way to do this.
But now that corporator is supporting them. The people.
Hopefully, good. That's the best way that they can do it. Yeah. Yes. So this is one of the things we do want to take forward at the clinics. We are at 14 branches now, I think, for us. One is expanding branches, but more is, can we do this work, go a little deeper, and automatically in that consult, the diet starts coming in a more rigorous way. We've started doing food workshops with the community as well. So yeah, those are some of the other things. Good. Yeah, that was I think that's broadly it from my side. If you guys have questions, comments, feel free. Madhuri, you want to add anything more? What's your plan for SIMSI? Since you're here, I'll interview.
So for next few days or few months, plan is to to establish a system where we are giving appointments to the patients and patient coming. Generally, we see that people gets the appointment from clinic, but here we are now building a system where we are giving the appointments like slot, that this is your slot and please come at this time. That is the big intention. And second intention is really start integration of yoga therapy and allopathy at all clinics in next coming months. That's the biggest goal. Yeah. And saying also, I'm getting goosebumps, but yeah.
Yes. Shava.
Tanush is checking.
Goosebumps. He's very fine. Okay. Yes. Questions, comments? We have a few minutes. Then we can close. Sita saying all the best. MM. Yes, Mercedes. Go ahead.
Hello to everyone. First of all, congratulations. I am so astonished and so happy to see the work that you have been doing as with allopathic medicine, with yoga. And my next question is, how can I help? I was curious about this workshop because I'm planning to stay in India for some months, for a long time. I don't know when. And my purpose is to do some seva, some service. So I just joined this for curiosity. But my next question is, what can I do for you?
So, would you be in Bombay when you are here, or?
No, I don't know yet. Maybe Jodhpur or maybe Pune.
So, in terms of, I think supporting, there are a few ways. One, I think spreading the word about the work that is being done both in India and outside. I think both help. So in India, for example, very recently now somebody has approached us from the Nepal-Bihar border. They want to start a center there. So we said we'll support them, like our technology platform, our SOPs, those are standardized. So we don't need to run. If there is a local entrepreneur who's ready to run it, organize it, get it funded, they can run the same system there. And we will, so they don't have to go through this 13 years of learning the hard way. We can try and give them and also support them. We can train them to start with. So that's one way, that just spreading the message, spreading what people, if people want to take it up, how they can take it up. Of course, supporting in any way the cause here itself in Mumbai as we do it. So if you know people who are interested, all our staff is largely, the staff part is full time, but some volunteering also helps, some seva helps, but also people who are interested in doing this kind of work. So this is always a shout out to all the yoga coaches also. If you are interested in Bombay and you want to do this at the clinics, do contact Madhuri. Hopefully we can work out something that you can support us in taking it to the masses, because we do need that, and we need more of the yoga coaches who can support this work. Others who are interested, if you know, we can always. Chalo, you have Sita is volunteered now, so good. We look forward to it. I'm sure. Yeah, Madhuri is happy. So that would be there. And last but not the least is funding. I think as you saw, it's not a lot. I think it's not. We've tried to reduce the cost. This is just bare minimum cost that we are able to do, but everything counts. Every little bit counts. To support one person is, like I said, just $5. So from starting from there, it supports, and the more people can support. So part of our, yes, we get funding from some bigger sources, CSR, but we also want a much more retail funding model also, so that more people are involved in this. It also raises the awareness, the consciousness of this whole issue. So how we can get more people to support. I think one of the things in Mumbai we do want to try at some stages, can people support there if they have their maids, their drivers, their house help, can that middle class support to at least their own staff members, healthcare expenditure. So those kinds of things we are thinking of, but even from outside, anywhere it's helpful. So funds are definitely one of the key things. So we have all kinds of, we are a very transparent organization, all kinds of approvals, certifications we have. So we get CSR funding, we have FCRA, so foreign contributions. So we have been doing that for more than almost 10 years now, at least 9 years, very actively raising these funds, and all very transparent. So you'll get clear reports. So again, people in corporates, I'm making a much larger appeal beyond Mercedes. If you know corporates who are willing to do CSR, individuals, our website is there. You could just go, there's a donate button, click, and every rupee counts. It's everything is important, nothing is small. Whatever, and the more people you can get, very simple match. It's 500 rupee a person a month, right? So that's it. It's 500 rupees for one person per month. That's the cost of supporting one person, preventing one family from impoverishment, you can say. Right? So yeah, if we get enough people to do it, I'm sure we can support at least this much, a lot of it. So yeah, those are the ways. And if you are in India, whenever you do come, do visit, spend some time. Yeah, it's always helpful. People who are already there, visit, give your feedback, share your ideas, what can be done, and we'll try and see. We are very open. We keep experimenting. Learning is like in our DNA. We don't give up so easily. We keep learning. So good. Sita ji ke liye plan will start making. Madhur will start making a plan.
My elder one is already pushing me. He says, take BRS and go and do what you feel like doing. Like, don't bother about all this nonsense. Oh, yeah.
When is your retirement due, by the way? Official?
Another 2 years.
2 years? अरे, मुझे तो 1 लगा था, तो थोड़ा ज़्यादा खुश हो गया.
That's why my elder one is going on telling me, जिधर तुमको खुशी मिलता है उधर जाके काम करो, जिधर नहीं है उधर क्यों कर रही हो?
Yes, Kalpesh.
Sandeep, are there any opportunities to work, contribute remotely? You have mentioned about, say, coming to the clinic or Mumbai and I want to contribute in some ways working from Bangalore. Are there any opportunities like that?
So, I think in terms of time, technology stuff though will be there. If you are able to do that, that will help. I know your skill set. That's why partly. The other thing we are, as I said, we are beginning to do is support other organizations now to do this and other work, and that we are setting it up where we are charging some fee also to create some cross subsidy now for this. So even for example, the institute, the revenue from the institute is creating a cross subsidy to the clinics finally. So that's part of the reason why we shifted to a revenue or a fee-based model at the institute, so that the institute cost is covered, but the surplus comes here. So it supports that. And similarly now, like our technology platform is there, which we are trying to give to others. In fact, there are two parts to our technology platform. The ERP solution is generic for all NGOs. So we want to create it like a business, charge fee, get a revenue, and again that revenue comes here. So right. So that's very generic. That doesn't require anything to do with health, but it's a skill that you are contributing. One is contributing, can do that. Same with other services like consulting, etc. through that entity. So that's what one of the ways. The other which we have to think, I think even as we are discussing today, some stuff, things like calling up patients. There are a couple of things which you do over a phone call. So people who can commit more dedicated time, then we can allocate some patients to them. Like they can become patient educators at least, right? From which can be done on a call. Sometimes we send WhatsApp messages. So all that just to keep the patient engaged. And that's part of the effort to take this 60% to 70, 75%. So how we can keep people engaged and keep educating. So people like you saw no, on that list, BP is gone up. They are not visiting the clinic. So somebody needs to call them, remind them. So those kinds of services we can think if we can do it in this remote way. But that will reduce our cost instead of having a cost. So if the volunteers are doing it, that will be helpful. It will make it more effective. That is something we can do. Any other thoughts, Madhuri? You think what support you can get for people remotely? Because that there are. I remember during COVID, we did some of these calling, right? At that time also remotely, where we were calling up. We made a whole system on COVID prevention. What are the caveats? This was right in April 2020. So April, May, we did that calling. Our team was just calling up all our patients because we had their numbers and then educating them. So if we can think of something, Madhuri?
Wherever there is necessity of like calling the people for appointments, like the capacity is like really restricted, less capacity in clinic. So whenever necessary, that would be really helpful.
Yeah, and that can be WhatsApp calls also. Most people have WhatsApp at least. Most. Okay. Good. Any
And
other?
one more help. So if you have any contacts in the medical field or the doctors, do let us know. So that's the biggest need now. Yeah, I want good doctors.
Madhuri and Sandeep. I'm a part of this group of doctors where we are a team of for emotional intelligence. So there are many doctors and many professionals, and they're all over Maharashtra and maybe even others. So let me have a word with him and to see how we could get you connected, talk, and maybe prepare a small this thing wherein if I post it over there, also you will get a lot of responses.
Oh.
So if you want JD and all, I can give.
JD is what? Sorry, I didn't get that.
Job description.
Okay.
Yeah.
I have one question for Sandeep and Madhuri. One of my friends who lives here, his dad is a doctor and he's based in Bombay, and he's sort of like approaching retirement. I think he's like a year or two from retirement. And there was some kind of curiosity about whether he could come and maybe like work with Swasth at the centers. I don't think he would want to do it full time.
Yes.
But is that something that we can look at?
Madhuri, go.
Yes. Yeah, volunteering like consultant type thing he can do. Yeah.
Okay.
Yeah. And some help in like technical interviews or where really the technical expertise is needed, then he can intervene there. I can seek support there.
Okay, let me follow up and see if I can connect the two of you. Might take a few weeks, but I'll follow up on that.
So that will be very helpful. Basically, I think both Sita and Andy and others, we have requirement for two kinds of profiles. One is a person who can come work at the clinic, and there we have kept a minimum requirement of 3 to 4 hours a day commitment. Right, so somebody who can spend, they can do it even 3 days a week. That's also good. Typically, it's 6 days a week. So right from 4 hours, 3 days a week to 8 hours, 6 days a week. We have doctors engaged at this level. So based on whatever they want, if they want to do clinical work. And the other requirement is with somebody with a more specialized skill set, more experience, him acting as a supervisor, a mentor to our other doctors, or taking up more difficult cases on a need basis, training, etc. That's typically an MD profile or a very senior, like a retired, just close to retirement MBBS, who may have worked a lot with these patients. So both of those. So these are the two profiles of people that we are looking.
I will leave, Sandeep.
Yeah.
It's fine.
Yes. Yes. Thank you.
Thank you.
Thank you. Thank you. Okay, we'll close. Anything else? Otherwise, I'm around. Thank you. Thank you, everyone, for joining.
Yeah.
Bye.